The thoughts and opinions on Just Some Podcast are of the hosts and guests and do not represent the views of organizations that employ them or they volunteer for. They are also not responsible for spontaneous black holes or nuclear wars that may occur. You have been warned.
Welcome, everybody, to another fun-filled and exciting episode of Just Some Podcast. This is Tom.
Hey, this is Ben. Tom, man, how's your week going, bud?
So far, so good. You know, a couple things. One, I am a huge NASA and space nerd, and we just passed the 50th anniversary of the moon landing and man walking on moon. And if you are a person that doesn't believe in that, like it's a conspiracy, please stop listening to us immediately. And go jump off a bridge because that's where you should go. But so that's that. But also weirdly, and like this literally just happened. I got that kamikaze nausea. I was literally fine 5 minutes ago, and now I'm sweating like, oh, I think I might have to go pray to a porcelain bowl here in a few minutes. Like this is not good.
Not having any crushing chest pains or anything like that, right? This isn't the big one.
Is that bad?
Yeah,
is this bad? Is chest pain and shortness of breath? Is that bad with this diaphoresis? I don't know what's going on. But I'm also super excited because we are finishing up Mental Health Month and we have a special guest. Do you want to introduce him, Benjamin?
I sure would. So yeah, we have a psychiatric nurse practitioner on the show tonight. Eric, hey man, welcome to the show.
Oh, thanks guys for having me. I really appreciate it.
So Eric, how long have you been a psychiatric nurse practitioner?
So I am coming up on the 4-year mark, I think in December.
Awesome. And we were talking a little bit pre-production. That was actually your entire goal, like, you know, because I know a lot of people go out and get their FNP and then they'll go back and get kind of dual certified and get their psychiatric nurse practitioner, but yours is just the psychiatric nurse practitioner, right?
Yeah, correct. So kind of my background, I worked as a float tech and I also played college football in a very terrible Division II school in Missouri. And so because I'm on the bigger side, I got floated to the psychiatric unit quite a bit and had the opportunity to see a psychiatric nurse practitioner work down there. And I'm one of the lucky ones that kind of knew that this is what I wanted to do from the very beginning.
That's pretty cool.
Yeah, I find it always amazing in the male nursing aspect, being not a small guy myself, that when I did work float pool, it's amazing how often, if there was a problem or they needed somebody, I always seem to end up on psych. I just found that odd that guys always seem to get floated up there.
Yeah, psych and one-to-one staff supervision for patients with dementia.
Oh, yeah.
That's all I did during the float pool.
Yes. A lot of.
Yeah. Many times in the ER when I'd walk into the room, they're like, oh, shit, they called security. I'm like, no, I'm your nurse.
Yeah, especially if it was a guy that was a little handsy with the female staff. I'd be like, oh, I'm going to take over his care now. I got room 5, so go ahead and just give me their meds, and we'll go from there. It honestly, it usually took one time of me walking in and going, I'm here to give you a catheter. Suddenly, they could behave perfectly. It's amazing.
I worked as an emergency trauma nurse for 3 years before grad school, and same thing. Same thing.
Yeah. So what position of football did you play? Because I'm guessing guard.
Well, so in high school, I played offensive center and defensive end, but getting to college, you know, being 6'1", 220 pounds isn't quite the right size for
so like
offensive line.
Linebacker.
Yeah, so I actually ended up transitioning to a fullback position.
Oh, okay.
Nice. Yeah.
Nope. Played a lot of fullback and linebacker myself, so hey, I understand. I loved it. Every play, I was like, I get to run full speed and hit somebody. I was like, Jesus, this is amazing.
Yeah, way better than having to stand there and let a linebacker come and hit you. So.
Oh, yeah. or receiver. Like, oh, you're going to run a fly route for no reason. Go 60 yards downfield and then walk back. Like, hell no. 7 yards. I'm going to run into you. It's going to be done. So there you go. It was amazing. So, okay. So enough of that. We could talk about that all night, Eric. So, and I know
sure.
Ben's a big football guy as well. So, we could be into that. So let's just keep this trade moving. We'll get back to that later. Ben?
Yes, sir.
Oh, so the listeners don't know. We found out in pre-production, Eric said, you guys sound like a bunch of bumblefucks. I've never listened to your show before. And so he doesn't know what's coming up. So, Eric, this is, I'm totally putting words in Eric's mouth. This is Ben's favorite part of the show. So, Ben, would you grace us with the social media shout out?
I sure will. You can find us on Facebook, Instagram, Twitter, and YouTube, all at Just Some Podcast. You can find us on the web. We're at www.justsomepodcast.com. You can email us, admin@justsomepodcast.com. Also, don't forget that you can find us on our podcast hosting device. That is justsomepodcast.libsyn.com. And we are also on Helium Radio. That is Helium Radio Network. Helium Radio After Dark, Channel 2. Thursday nights, 9 p.m. Eastern, 8 Central. Tom, what else can they do, man?
Did you mention YouTube? Did I hear YouTube in there?
Yeah, it's Facebook, Instagram, Twitter, and YouTube.
I was so mesmerized by that golden voice that I thought for a minute I had missed that. So what else what else? Oh my God, words are hard.
Words are hard.
So what else can they do, Ben? They can give us some ratings or reviews. They can tell all their friends on any of those social media sites that you just listed. They can also go to our website. At the very bottom of the page is the Amazon affiliate link, which they can click on and then go do all their Amazon shopping. That link is used quite a bit, so we know you guys know where it's at. Thank you so much for supporting the show. It costs you nothing. You can shop just like nothing has ever happened. But before we're done with the social media,
yes,
we got a couple things to talk about social media wise, Ben.
We do, Tom. So we have been talking the last several weeks, and we were in 49 states, Tom. We had one holdout state, Vermont, and I'm happy to report, Tom, as of this weekend, maybe it was Jamie's episode, I don't know. But as of this weekend, we have all 50 states, Tom.
Well, first of all, I'd like to say thank you for getting your damn act together, you troll-dwelling jerk faces up there in Vermont. But I'm glad. I know you said I have to be nice. Yeah, blah, blah, blah. Yeah. So, but I mean, look, don't you imagine Keebler elves when you think of people from Vermont? Like, seriously.
No, I'm
the
sure
EO fudge cookies are being produced at high rates of speed in that state. I know it. So they're known for like maple syrup, waffles, and Super Troopers. Like, do they really have a lot going on up there? I don't think so.
After that, I guess we got the one download. We're probably more now. Thanks, Tom.
Well, I love them. I'm glad. I mean, you can't have pecan waffles or pancakes without maple syrup. So, I mean, they are contributing something, I guess. So, I mean, we got that. So, hey, Vermont, thanks for joining the damn party. It's about time. But
speaking of joining the party, go ahead, sir.
I'm super excited. So we have Eric, so you know, and maybe you could diagnose us later with our illusions of grandeur or something, but we have 2 hashtag missions on the show that we've developed. The first one being we want to be played in Antarctica.
So hashtag Mission Antarctica.
Yeah, so that way we could say we had global dominance. So we were on all 7 continents. The last one is hashtag Mission Galactica. Somehow we're going to get played on the International Space Station or just downloaded in space in general, but I'm assuming it has to be at the space station.
That would be pretty impressive, guys.
Thank you.
And we are able to check one of those off, aren't we, Tom?
That's right. Mission Antarctica is a success, Ben. We have been verified not once, but multiple times now to have been downloaded in Antarctica. I don't want to give away specific details because apparently, unbeknownst to me, there's just stuff you don't talk about in Antarctica, which was that's a whole nother episode for other reasons. But basically, we were told that I could say a foreign country. I'll say a foreign country. We can say Norway, right? A guy from Norway got a hold of us on Facebook and said, hey, we liked you guys. We happen to have some decent bandwidth today because apparently that's spotty. That's one of the issues with downloading in Antarctica. And yeah, it's done. We're downloaded there. Plus, we have another crew that has discussed they weren't sure if they're going to be able to download, but they were going to download our episodes prior to going and then play us and listen to our show while in Antarctica. So we're counting that as a double win.
Yeah, I mean, we go from nobody to at least 2. So yeah, I want to give a huge shout out to the gentleman from Norway who's currently listening to this. We appreciate you listening. And to the other people who reached out to us who are going to be going to Antarctica in October, we appreciate you also.
Guys, I don't know if I can keep on this podcast. I thought this was going to be a little thing, but y'all are 2 celebrities I'm hearing right now.
Oh, I thought he literally meant like he had to go. I'm like, well, damn, Eric. It's only 10 minutes in. So let's say, Eric, for argument's sake, that 2 guys come in that look like a bunch of homeless guys, and they're like, hey, we got this thing where we want to talk to somebody on the space station. What exactly would you do next?
Well, I'd have you schedule, sit down, get some police coming on the way, and get you guys the good stuff.
Okay, so what if they said, oh, by the way, we're well known in Antarctica as well?
Yeah, if we tell them to turn the lights on.
Good to know. I don't know if we have posted that on some social media. I think we were waiting on at least one of those, but I think the cat's out of the bag now. So I know the guy from Norway is on there, but I don't know if we had talked about the other one.
No, we hadn't talked about the other one, but yeah, the gentleman from Norway did comment one of our Facebook posts and said, greetings from Antarctica, and he downloaded it. And
yeah, I don't want to release any names at this time because, like I said, apparently some issues are sensitive. So just know, the people that have contacted us, that we know you're listening and we love you guys, and thank you very much. So Mission Antarctica, check. Penguins rocking Words Are Hard shirts and drinking out of Words Are Hard coffee mugs in Antarctica, check. Yeah, that's a whole thing. We're big time, Eric.
Guys, I'm more and more impressed. I need to get me a mug. I need to get me some T-shirts.
The socks are the hot items, from my understanding.
You know, I like to think I've got some fashionable socks working in psychiatry. You know,
yeah, you have to.
One of the residents I used to work with, he would always give me a hard time saying part of knowing you're established is the kind of pattern you've got on your dress socks. So apparently that's a big thing.
I imagine Eric right now wearing like a tweed houndstooth jacket and like a bow tie at the moment. Like, yes.
Absolutely. Hit the nail right on the head.
Oh, yeah. Yeah, I bet. Or Ogre from Revenge of the Nerds. I don't know which one, but it's probably one of those 2.
Yeah, second one's the closest.
That's okay, Eric. I look like a bowling ball with a face, so it's not really that big a deal.
Right. Tom, you ready to do the stories that we may have missed?
Yeah, so like I said, we kind of prepped Eric on this part. This is the stories we may have missed. So, Ben, you got a story for me?
I do have a story for you, and this one I do not think is going to upset you or piss you off. We're going to end Mental Health Awareness Month on a good note, Tom.
Okay, well, I'm looking forward to that.
There are 2 states now, Utah and Oregon, where they are passing laws to allow mental health days for students. So on July 1st, a law in Oregon went into effect, giving students 5 mental health days in a 3-month period. And then in 2018, Utah changed the definition of students' quote valid excuse to miss a day to include an illness which may be mental or physical. So according to a 2017 report by the CDC, suicide is the second leading cause of death for 10 to 34-year-olds. And then a 2017 Youth Risk Behavior Surveillance Report showed that during a 12-month prior to the survey, 19% of high school students had been bullied on school property, and another 7.4% had attempted suicide. So I do think that, we're getting some mental health awareness even in the schools, to where it's, if they need to take a mental health day, then they have that ability, at least in 2 states. Tom, your thoughts?
I think I'm not upset, by the way. So let's be clear. And I'm glad Eric's on the show. I think I would love to hear his point of view on this. And I'm going to say something that's going to sound unpopular. And I am totally mental health is health. That's why we're doing this. We did it. We dedicated this month to doing mental health awareness. Obviously, Ben and I support mental health, and we are out to improve care for our patients in all ways, including mental health. I wonder, in my head, looking back, I did not have a rough time in high school. Doesn't mean it was perfect. I didn't have some of the issues that you discussed. So maybe my view on life in high school is slightly skewed. What I will say is, at what point does it become a mental health factor? Which I am not saying that there are not mental health issues that require mental health days or illness excuse. Let's put it that way. Like, let's say the kid said, I needed today off because whatever. I have no doubt that that's true and exactly right. But at what point, and this is a fine line, and I'm not saying I have the right answer, are we saying, hey, children, you don't have to learn how to deal with life. You could just call timeout and step back? Or when are we going to start saying, no, you have to learn how to deal with this? You're young. That's the whole point of socializing while in school, is to figure out these things and push forwards. Again, I'm not saying there are not times and places where it's legitimate, but to just say a blanket, oh, by the way, every 3 months you get 5 mental health days, just starts to yell to me like, okay, at what point is individual responsibility and teaching that going to become victim to protection? Eric, what do you think?
Tom, I have a tendency to agree with you to an extent. There's this thing that I reference a lot when I'm working with students that I may take on who are psychiatric students, or speaking with therapists, and some of the older psychiatric nurse practitioners or psychiatrists out there will understand what I'm talking about. But there's this thing called ego resiliency. And it refers to the very thing that you've discussed, is someone's ability to persevere through adversity. And that's one thing that I try to evaluate as I interact with each and every single one of my clients, is what is this person's ego resiliency? How likely are they to have a good prognosis in the face of an adverse event, such as losing a loved one, being bullied at school, so on and so on? I think there is a fine line, Tom, and I don't have the answer to that either, where we need to be making sure that we're instilling enough support to where they can persevere through adversity so that they can use that later on in life. One thing I do want to point out, I do think the benefit of mental health days could be there for the right people. You would want to implement, you'd want to look and see, is there a pattern to this kind of behavior that could lead to truancy or other secondary gain with someone missing school. Another thing that frankly hasn't been addressed, which I believe is leading to more self-harm in the school-age children, is the effects of social media. Back in the day when I was going to school, I could go home and get away from it. There might be some kids in the neighborhood that would pick on me or give me a hard time, but it wasn't to the point where I'd be getting notifications on my Facebook account or my Twitter account or whatever other social media there is out there. I think addressing and understanding that some kids do need a break. On the other side of it too, the ability for a kid to go to school may be a break from their stressor. I came from a wonderful home life. My dad was a police officer. My mom was a nurse, and we weren't rich by any means, but I didn't have to worry about whether or not I was going to be eating. The opportunity for some of these kids to go to school is an escape from their home life. And I don't want this to be construed or taken or have these mental health days taken advantage of to where we're taking these children out of the place of education and support.
Going off what Eric said there, I mean, Tom, I don't necessarily disagree with you by any means, but I just think it's a different world that we're living in now than when you and I were in school. Like Eric said, it's this society that we've built. It's this immediate gratification society. That's why fast food and social media and everything is so huge, is because you get that instant gratification.
The dopamine hit.
Yeah. The flip side of that, however, though, is, cyberbullying is a very real aspect, and you can't get away from the internet. I mean, you can, but it's much harder to do that now as opposed to when you and I were kids.
No, I agree with both of you. I'm not saying that I'm not even saying there is a good answer. There may not be a good answer. All right. There may be an answer, but it's not going to make a lot of sense in a lot of ways. I find myself stuttering thinking about this, obviously. I agree with both. I think that social media has insidiously invaded our lives, and while it's great in some ways, the harms that Eric were just talking about, like I said, I had a great childhood for the most part. I mean, it started off a little rocky. We were a little poor in the beginning, but things picked up and things ended up okay. And like Eric said, I was lucky, and I recognized that even then. I recognized even then, I wouldn't say I was highly privileged, but I also didn't have to worry about food.
Right.
And that is an advantage I recognized even then that not every other child enjoyed. However, at the end of the day, if somebody was creating a problem, I also had to learn how to deal with it, which I think is part of why I don't want to say the word successful, but I think I have persevered better in my adult life. And I feel, and I see this in some ways with my own child and other children around me, like the mothers are like, oh God, they do everything for them. I'm like, you aren't helping them. You are taking a learning experience from them in a safe environment, mind you. They're 7. If he falls and hurts himself now, he learns a valuable lesson that's safe versus you coddle him now and he becomes 15 and he thinks he can drive his car fast. Guess fucking what happens at 40 miles an hour in a car wreck?
Yeah.
And I think this is no different mental health wise. Okay. I think we are taking the opportunity for these kids to build and learn life lessons and skills that they can then have with them the rest of their life. And we are stealing that from them. Certainly there are mental health conditions that I believe. And honestly, like we went through a classmate of one of my sisters killed himself while we were in high school. And I don't mean it was an accidental, he was crying for help and somehow, I mean, this was looking back, I was like, holy shit, that kid he had a mission. And I truly think everybody could have done well to have a decompression day for something like that. I'm not saying there shouldn't be, but to just say that there's a blanket pink slip, oh, life's hard, I need a day off. Well, guess what? Eventually, life is going to get harder and there won't be a timeout. And we're taking away the chance for those kids to have that ego perseverance that Eric talked about that says, hey, I've fallen down before. I can get back up and move along. I don't want them the first time having a major traumatic experience not being able to figure out that they're going to live through it. And so I know that's probably going to come off poorly to some people, and it's not meant to be in any way. I support mental health 100%. I've been through some stuff. I just think that perhaps this may not be the most appropriate use of this type of situation.
Yeah, and one thing I want to add to that too, Tom, when we look at symptomology associated with mental health disorders, humans, we're pack animals. We want to be a part of something. We want to be part of a group. If you go back and you look at Erik Erikson's theory of psychosocial development, when we hit those teenage years, we're trying to not only figure out who we are, but we associate ourselves with individuals. My concern would be if we do have a young person who is struggling, whether it be depression, suicidal thinking, anxiety, I don't necessarily believe that the best course of action is to pull them away from additional support and to further isolate them from friends.
Afraid of like ostracizing them, basically.
Well, not only necessarily that, but social isolation is a symptom of depression. And one thing that I talk about with my patients a lot are the very thing that depression makes us want to do, we have to do the opposite. If depression makes it to where you don't want to wake up and take a shower, you do it anyways. If depression makes you to not want to go to work or school, you find a way to do it anyways. Because when we surround ourselves with people, prognostically things are going to be better. That's one of the benefits of group psychotherapy. When I did inpatient psychiatry work, that's why we wanted patients out on the unit. We wanted them having those interactions, even if they weren't necessarily the best. We know that interactions amongst humans are very important to recovery and wellness. And I have a couple cattle. When we see a cow out in the field and it's off by itself away from the herd, that's typically not a good thing. And I think the same thing can be said, and it may be oversimplified, but the same thing can be said in humans. There's a benefit to having that emotional interaction.
Well, I can't wait to read the emails where they're like, hey, Eric called me a cow. No, I think you misunderstood the point.
Yeah, no, absolutely. Wouldn't be the first time, but yeah.
Yeah. But I had to mute. I was laughing when you first said ego resilience. Now, I'm not laughing at that term. There's a movie called The Hitchhiker's Guide to the Galaxy. Has either of you seen that?
Straight up, no. I haven't. No.
No, okay. Well, there's a part in the movie, you'd have to watch it, but they're on a space ship because obviously Hitchhiker's Guide to the Galaxy. And the girl said, I think there's something important on the ship. He goes, if it's more important than my ego, I wouldn't have found and shot immediately. And that's all I kept thinking about was like, I got a pretty good ego. I must be pretty resilient. So,
I want you to think back to the early 1900s and Sigmund Freud's thoughts on ego states and what an ego meant to Sigmund Freud. And that's kind of where the term ego resiliency comes from.
well, actually, Eric, that's why I got you on the show. So you could tell me. I don't want to think.
Perfect.
So-
Perfect.
Oh, wow.
All right. Betty, was that the answer you were looking for to?
I can see the controversy behind it, and the article did mention that there are some parents who are opposed to it and some parents who are supportive of it. And so, I mean, it's walking that tightrope and trying to find the right answer. And like you said, I don't think any of us necessarily have that, but I think it's at least a step in the right direction toward recognizing that mental health is a legitimate concern.
And you know what? I guess ultimately I'm opposed to maybe blanket deployment of a resource like this because I think it's going to get abused or misused, maybe would be the better word. But I think the fact that they recognize that this is a legitimate issue that needs to be discussed and taken care of is a, like you said, a positive step. And I'm all for that. So even I would rather make a mistake in trying to do the right thing than sit back and sit out with a thumb on my ass and do nothing and then fail. If they make a mistake and it doesn't go perfectly, but they're trying, way better than these other states that are like, hey, we got children getting semi-automatic rifles and shooting up schools because they got mental health issues, but we're not going to address them. Maybe at some point, mental health needs to become a little more prominent, and I applaud them for trying.
There you go. Okay. We ready to slide into the rest of our episode now, Tom?
I don't know. Are we? Eric, are you ready for this?
Guys, I'm ready if y'all are ready.
This is where you make the choice between the red and the blue pill. We just see how far this rabbit hole goes.
Oh, no.
So I wanted to start just because there are some people that, granted, our show is supposed to be directed toward advanced practice providers, so NPs and PAs, but there may be people out there who don't necessarily know what a psychiatric mental health nurse practitioner is and does. So Eric, can you just kind of give us some background on what that is and what it looks like?
Yeah, absolutely. And I think it's a great question. So I went to the University of Missouri, Kansas City. It was a hybrid type class. So we did a lot of the didactic work online and presented a couple times a semester just to do skills check off, different things like that. So my background, when we initiate into the program or we start the program, we take the same courses as family nurse practitioners. So the theory, the pharmacology, and the health assessment courses.
Okay.
So I really felt like we got a pretty good background. Once we get kind of that basic advanced practice education, that's where we steer off and we go into specifically psychiatry and psychology and study neurobiology a little bit more, study psychopathology, pathology a little bit more, and then take a deeper look at psychopharmacology. So one of the things that was recommended to me, and I do like to share it, I was talking with that nurse practitioner I had the opportunity to observe when I was a psych tech, and I said, hey, I really want to do what you do when I grow up. And she looked at me and she said, go work on a medical floor in the emergency department or in the ICU. Go get experience because I want you to be able to look at a psychiatric patient and know if they are physically ill versus mentally ill. And anybody who's worked in the medical field, you guys have an emergency room background, you knew when a patient walked in and they were sick.
Yeah.
There was something in the air. You could see it in them. And I think the 3 years that I spent working as an emergency trauma nurse really prepared me. Because when we think about delirium, when we think about other medical conditions that could be causing hallucinatory phenomena or something like that, I think it's important to be able to look and see a patient if they're physically ill or have enough intuition to dig a little bit deeper.
So that brings me to another question. Sorry, Tom, and then I'll let you ask.
No, go ahead.
That knowing that someone is medically sick versus psychiatrically sick, let's try to oversimplify it here, but is that training that you kind of received through your psychiatric program? The reason I ask is because one of the podcasts that I listen to is Pop Psych 101, which has a licensed therapist on it. And one of the things he talks about is as he is going through and talking to patients and doing that, he's always in the back of his mind, making sure that it's not something that is medically relevant to where he needs to say, hey, you need to go see your primary provider because I think this is more medical versus psychiatric.
Yeah, so the American Psychiatric Association published a diagnostic tree, which I recommend for every early clinician in their psychiatric career. The common theme on on each diagnosis that came through, one, the first question you have to ask yourself, is this a medical condition? Can you definitively rule out that this, whatever is going on, is not due to a medical condition? The second, is this due to an illicit substance or a prescribed substance or a prescribed medication? And so absolutely, every person that I look at, I think to myself, is this a medical issue? Having the background of taking the same health assessment courses as the family nurse practitioner group, that was one thing that my professor dug deep into us is, hey, are we ruling out that this is a medical etiology? And so absolutely, when I meet with patients, I'm constantly ordering labs and really teasing out if these are physical symptoms or these are somatic symptoms of a mental health condition.
To say, I remember vividly from ER and working at trauma centers, okay, he's seeing things, but he just did LSD a couple hours ago, versus the female patient that tried to murder her child, and you start talking to her and you're like, no, she's not there. This is not an act. This isn't a drug. Like, that person is legitimately needing help I can't give them. So I think it's awesome that person in your life gave you that advice first. And also, I would like to point out, I am a UMKC grad as well.
Go Roos.
So yeah, go Roos. I was yelled at when you said it too.
You guys are going to have me back on here next year.
Oh yeah, I was gonna say, we're gonna talk off air, but yeah, this is a thing. So now that we know, otherwise I'll start rambling. So now that we kind of have an idea of what a mental health nurse practitioner does, where do you find yourself? Like, someone wants to see you. Are you working in clinics? Are you working in hospitals? Where are we most likely to find mental health nurse practitioners at?
Well, the really cool thing is over the last few years, it's been diversified. As many of you know, not only are we experiencing a primary care shortage, but we're also experiencing a psychiatric shortage across the country.
Yeah.
And that affects everywhere. That affects primarily outpatient substance abuse treatment centers, outpatient clinic centers, inpatient psychiatric units. And so my history, I've done a little bit of both. I'm currently doing primarily outpatient psychiatry work, which I really enjoy. One of the really neat things, and I tell this to all of my patients, hospitals are where people get stable. They don't get well. And so if you have a steady diet of inpatient psychiatry, you never see them get a job. You never see them be a great parent. You never see them graduate from Alcohol Anonymous or Narcotic Anonymous. You see them at their worst. You get them just well enough until the insurance company or hospital administrations want you to kick them out the door. And so I like outpatient work. Man, it's really neat to see them grow and just do great things in society and be productive members of society.
So I like the fact that you kind of have a background as far as some of the same courses that a family nurse practitioner would take, as far as the health assessment and the classes like that. I wish that there was, and I've said this before, I wish there was more psychiatric medicine in a FNP program, because, as you well know, I'm sure, a lot of patients, because of the stigma of going to quote unquote mental health, they will go to their family provider and try to get help there. I did not realize whenever I was going through clinicals and when I first got out of school that 60-70% of what I'm taking care of in the clinic, yes, it may be an acute illness, but there's still some mental health aspects attached to that. So I just wish I like that you have that background. I just wish that there was more of the psychiatric background in the FNP program. So my question then would be, what are your thoughts on those in family practice prescribing antidepressants and anxiety medications, psychotropic medications, things of that nature?
We do it out of necessity. I had a psychiatrist talk with me one time, and he said, Eric, for every depressed patient out there, it would be great if they could see a board-certified psychiatry provider. But that's not the world that we live in. I think there are a lot of rating scales that can be utilized to kind of help you all at your job. But the fact of the matter is, I get an hour to do psychiatric evaluations, and I have 20-minute follow-ups. For my peers working in the family practice setting, how many times have you guys had an hour to spend and talk with your patient?
Never.
Not much.
They would say 0.
Yeah.
Yeah, and I'm specifically targeting mental health symptoms. And so to get back to your question, sorry, I have a tendency to ramble as well.
No, you're fine. You're fine.
He's got to fit in so well.
No, thanks. To answer your question, I hand out my cell phone number to family practice providers so they can call me directly to see if they need to work in one of their patients. If not, I share current literature. We talk about kind of what the practice recommendations are for a variety of different mental health issues. And I empower them to trust their judgment, trust their intuition, and initiate treatment. Because we have to. There are not enough board-certified psychiatric providers. We need our peers in primary care and family medicine to step up to the plate and help.
Because I was thinking, I saw a documentary. It's called Code Black. Not like the television show. Don't ever do that to me or watch that. But it's a legitimate documentary called Code Black. It's on Los Angeles County's emergency room, where modern emergency medicine as we know it was born. And it was funny because the specific example they used is that hospital, like every hospital in America, did not have an emergency room. And so whoever was walking by, and in this one case, they were retelling the story, it was a psychiatrist. And the person was having chest pain. And they were clearly going and having a heart attack. And they're like, hey, help this guy. He's like, what am I going to do? He's like, but he was who was there. And that's how they treated ER medicine. Whoever was there caught the case, and that's how you dealt with it. And over time they recognized, hey, ER medicine needs to be developed, etc. I know obviously we recognize psychiatry. I just think as time goes on, we will start to perhaps embrace it more and take it that next step. And I think hopefully in the future we will see a beefing up of our ability to take care of mental health patients. One of the questions, and I'm sorry, when he said that, you take care of whoever gets it, I was like, yeah, I've seen that in reverse. One of my questions for you then is, well, I guess it's a two-parter. One, what are some things you suggest to mental or primary care for taking care of mental health or making that initial decision on medication? And two, what do you see the future of mental health and family? Do you think we would ever perhaps merge, or maybe we make mental health a stronger component and we make everybody family nurse? Like, what do you think about those two things?
Well, first, my recommendation to any person who's treating mental health disorders, and I could talk about this forever, so I'm going to keep it brief, have a good idea of what you're treating. There's a couple things you don't want to miss on. You don't want to miss on somebody who has bipolar disorder and you put them on an SSRI, which could be stimulating to them. Everybody thinks about SSRI-induced mania. My concern is the SSRI-induced mixed episodes, where we have someone who has depressive symptoms in combination with manic symptoms. That phase of illness is the highest phase of suicide completions. So bipolar mixed episodes, we want to be evaluating for a history of a manic episode. You can utilize the mood disorder questionnaire to do that. Otherwise, trust your intuition, initiate treatment. And if you're starting to think that you're outside of your comfort zone, or you may not know what's going on, find a way to get them into psychiatry.
Okay.
To answer the second part of it, I think integration between all branches of the medical field is incredibly important. We do that at where I work. I have internal med physicians, internal med nurse practitioners come knock on the door and ask me to lay 5 minutes on that patient. For me, that delays me getting my charting done. That may make me run behind, but 5 minutes with someone who is trained in psychiatry can be the difference between a medication mistake and getting them off on the right step. It also gives me a chance to do a quick triage assessment and determine if this patient needs to go to the hospital or if this patient can wait to see me in a couple weeks or a couple months. But I think integration amongst the medical team is going to be the most important thing.
I had a question and then my mind just went blank.
Is that dementia, Eric?
Yeah.
It happens to me all the time, so I hope not.
So, Eric, what would you say top 5 things that you routinely see, like in a given week? Like, do you have certain things that you see a lot of, and what would those be?
Yeah, so major depressive disorder is common. It's one of the higher prevalence of disease states of mental health. Anxiety disorders. I have a lot of people coming in telling me they have panic disorder, but they actually don't meet diagnostic criteria for panic disorder. Unfortunately, practicing in Kansas, there are very high rates of physical, sexual abuse. I do see a lot of trauma-related disorders as well.
Do you see much substance abuse?
Oh, Yeah, I left that one out, Ben. Absolutely. One of the things that I do enjoy doing is I do work with addiction treatment services. I am a waivered buprenorphine prescriber. Substance
Nice.
abuse is kind of near and dear to my heart. I do like working with people in recovery and people who are coming in and out of recovery.
I say I just recently got my Suboxone waiver as well. I haven't started on that front, but where we live, there is a high amount of narcotic. Because obviously I live far away from Ben now, and that's good because it's way better here. But we have a large IV narcotic heroin use here, so Suboxone's kind of been something I knew I needed to have that tool in my tool bag. But I'm kind of, wait a second, you're doing mental health and you're not seeing a lot of Capgras or Cotard syndrome, is what you're telling me?
Absolutely.
Oh, see, now I want to do it. I want to talk to that guy. So there you go. I feel because like when you're in ER, everybody thinks every day is like, well, the show, and I'm like, no, most of the time it's 3 a.m. toe pain. You know, so
you're an emergency room nurse for the 1% of the time. It's a honest to God full blown emergency. You know.
Yeah. I try to tell people all the time, no. Most of the time I felt sick for 3 hours and decided to go to the ER. So
that's not to minimize the importance of adequately treating depression or adequately diagnosing bipolar disorder. Just imagine for a second, you spend your entire life depressed and you go in and out of mental health providers or you see a variety of primary care people and nothing ever gets better. You're not to the point of where you're wanting to commit suicide on a daily basis, but you're dysthymic. You're unable to really enjoy or get satisfaction from the wonderful things that are around you. Some of my best work has been adequately treating depression, which seems like such a minute thing. But to get someone who's been depressed for 20 years to come back to your office and tell you, I enjoyed the sunshine today, as silly as that sounds, it's incredible. And they'll cry, and it's hard not to get emotional when you have those kind of responses.
Wow. I can see, I'm at a loss for words. Sorry.
I didn't want to sound, I'm sorry. I didn't mean to sound like I was minimizing those other conditions. I just think, especially like when you listen to show, like I love pop psych as well. Sometimes we hear or focus, like when you watch a movie, everybody talks about multiple personalities or dissociative identity disorder, but nobody really talks about the grinding work it takes to treat major depressive disorder.
Oh, yeah.
So sometimes I think it gets lost in the mix.
Yeah, absolutely. And like I said, one of the things that is one of the biggest improvements in people's lives is just bringing up total satisfaction. We talked about dopamine and the nucleus accumbens. That can be an incredibly powerful thing. And I didn't take it as if you were minimizing it or anything else like that, but sometimes it's the subtle things that make the job absolutely worth doing.
Like I said, I can see the personal satisfaction of that. I mean, I get some of that on the medical side of it too. I've had patients come to me who've seen multiple other providers and then we're able to finally figure out a treatment option that's working for them, or we are able to finally give them a diagnosis, and that relief that they feel, and that it's kind of makes you puff your chest up a little bit, and you're like, yeah, I was able to actually help somebody. I was humble, I was able to impact their lives positively and make things better. So I think that's awesome.
Yeah, for sure.
Well, Tom, any final questions for Eric before we get into our last segment?
Yeah, so I had a dream the other night, right? And I was covered in baloney. I'm joking.
I don't do dream interpretation. It's a slippery slope, and I am not near well qualified enough for that.
Especially when you're covered in baloney, Eric. When you're covered, it's slippery all over the place. Okay, maybe that's why she was throwing Jell-O at me. She wanted me to be slippery. I don't know.
Nothing good comes from baloney.
No.
Baloney and Jell-O in a baby pool. It's fun for everybody.
That does not sound fun at all.
Well, Ben, you weren't there. So
live a little.
Yeah, I would say he might have been in the stands clapping. By the way, I was in front of a lot of people. Did I say that part? So I'm
even better.
I think I would rather shit in my hands and clap than watch that. So.
I was wearing a cape for some reason. I was joking. Okay.
I'm gonna have Eric
Okay.
off air and get you diagnosed and get you on some.
Yeah, for sure.
Yeah. Eric didn't realize we were bringing him on the air for the free treatment. So, Eric, what's it mean? No. So, I'm a new nurse practitioner. So, what are some? Let's focus on this. We've talked about some of the things we should do. What are some things we shouldn't do? Like, give me some of the big pitfalls that you want a new nurse practitioner in family medicine to try and avoid to help you help the patient.
First thing that I think is incredibly important, don't ask your patients for the medications that have worked in the past if you don't want to hear the answer.
Okay.
I treat people in psychiatry and I'm saying, hey, what's worked for anxiety in the past? And they're like,
Xanax.
well, I don't want to tell you because I don't want you to think that I'm drug seeking. And I'm like, I'll tell you if I think you're drug seeking. I'm not going to hide it from you. But what's worked? And then they'll tell me Xanax. You guys decide what you want to do with benzodiazepines. I'm pretty firm on the idea that I'm not going to perpetuate a substance abuse problem. But don't ask questions you don't want the answers to. Number 2, rule out bipolar disorder. Don't assume it's always major depressive disorder or unipolar depression. Please do an adequate medical workup.
All right.
I had someone that I saw, and they were older female who came to see me with a report of visual hallucinations. It was a referrer from primary care who didn't do any other further workup.
Oh, no.
And coming to talk with the lady, it really wasn't necessarily visual hallucinations. It was just a kind of a change in her perception field. I mean, you guys tell me, what's the differential for that? Are we going to make the assumption that it's a mental health issue when it's atypical that someone of this person's age develops new onset psychosis that is visual by nature, which is like, what, 12% of people who experience hallucinations, they're visual and not auditory?
We know a guy who had an olfactory one, just saying.
Yeah, absolutely. That's like, what, 0.5% to 1%, typically associated with some kind of prefrontal cortex issue.
Okay, so make sure we do adequate medical workup. You know what? I really like the don't ask a question that you don't want an answer to. Because I think that applies to more than mental health. I think that applies to a lot of things. And that's one of the things I remember from my Suboxone training was, just like you said, I'll tell you if I think you're doing this. We have to be honest. You may not like the answers, or I may not like the answers, but I need honesty. And so if you're going to ask that question, you have to deal with the repercussions of what you just did. So I find that is a very good piece of advice for us to listen as practitioners, regardless of mental health, is if you ask a question, you better be prepared to deal with whatever the answer may be.
Absolutely.
But those are the big things for me. I'm actually excited because I know what's coming up. So Ben, do you have any last issue?
I'm ready to go to our final segment. And
oh yeah. It's weird because we're asking the mental health guy these questions. I would have like later on, he's going to be like, my dissertation on why Ben and Tom are crazy based on 5 questions. So
right. Yeah, I'll know if he doesn't answer my text messages anymore. Why?
Yeah, absolutely. I felt so bad because Ben had texted me and I read it. And then I was so busy, I just put my phone down and then boom, it was gone. I was never going to remember it again. And then he texted me a second time and I was like, oh shit. Yeah, here, let me get back to you.
All right.
All right, here we go, Eric. Just prepare yourself.
All right, I'm ready. Let's go.
Join us on a journey into the inner psyche of our guest as we ask 5 questions.
Oh no.
That's the appropriate response. Thank you. So
we're going to find out what makes Eric tick. You ready, Eric?
I'm ready.
All right, question 1. What's your favorite medical word or psychiatric? I mean, for in your field.
Yeah, the entire field.
Oh man,
trauma, mental health, whatever. Like, have you ever heard a term and you're like, I really like that? What is it?
Tangential.
Ooh. All right. I like. Yeah. There you go.
Yeah. Can you use that in a sentence? No, I'm joking. So,
question 2, Eric. If you could do any job in the world other than what you currently do, what would it be?
Deep sea fishing,
like in the
either be crew, like deep sea fishing, like I watch Wicked Tuna, or fishing in the Gulf, being a fishing guide, or anything outdoors.
I'm going to be real honest. I did not see that coming.
Oh, you're welcome.
See, you got me. I was thinking, okay, here it comes, playing for the Chiefs. No, deep sea fishing got me. The only thing about that, I like the shows that you listed. I watched the original show that is based on, when it was just almost like a documentary. Like they did one show on the crab fishermen, and then it became this reality show. I was like, oh, I just like their original better.
I like being out in the middle of the ocean, not seeing any land, and just waiting for something to hit a fishing pole.
Wow.
And just chilling out, waiting, having a couple beers, just relaxing.
That sounds relaxing and terrifying.
Oh, no, it's pretty sweet. If you haven't done it, you should try it. It's life-changing.
Tom, that's probably my favorite question of the 5 that we asked, because that question, like when we had Brian on, and it was like, he wanted to be a saxophone player in a jazz band. That question is awesome. I love that question. That's my favorite question that we ask of the 5.
So I like almost all of them. My favorite is one of the ones, but purely for comedic value, which I think is coming up. So why don't you ask it?
All right. Question 3. Eric, I want you to think back to your first car. Was it a stylish ride, or was it a rolling turd?
Rolling turd, man.
See, purely for comedic value, that's my favorite question.
Oh, man, there used to be this unspecified white smoke that would come up through the air vents. My dad told me there was nothing wrong with it. Someone else told me it was antifreeze that was being aerolized, whatever. So, yeah, rolling turd.
Oh, God, what was it? I'm thinking like 88 Caprice.
No. So this was like a 15-year-old Dodge Dakota. Had about 180,000 miles on it. Window didn't work. You could hear me coming from a mile away because it squeaked so loud when you were driving it. Oh man, it was a shit show. It was a mess.
Did you name it? Did you name your vehicle?
I did.
Yeah, I knew it. What was the name?
Linda. No offense to anybody out there named Linda.
So Ben's gonna know who I'm talking about. We have a mutual friend who had it was an 88 Cutlass, had like the diagonal, like weird shaped front end.
Yeah.
Someone stole it had like the 2-piece grill. Someone stole the grill off of an 88 Cutlass, and credit to him, our friend came out, wasn't even that pissed off. I was like, it's the Grillless Wonder. That's the best name I've ever heard for a car in my life. Watching this 88 Cutlass drive around town with no grill. Oh, it's the best thing I've ever seen. Okay, so that's how I knew. I was like, he's got a name for it. I know he's got a name.
Oh, of course.
All my cars are named after a girl. So that's just my thing. Probably some kind of weird cycle evaluation coming up later on that. But yeah. All right, question 4.
Question 4. If your house is on fire and everyone, including your pets, are safe, what's the one thing that you want to get out of your house?
Oh, man, I'm going to try not to get too gushy with this answer, but probably all the pictures from my wedding.
Okay.
I mean, all the other stuff I can buy new. But when I get old and I can't remember who I am, I want to be able to look at something and say, man, that was a hell of a good-looking guy married to a hell of a good-looking woman.
There you go.
I would say that was assaultingly mushy.
but the end come around. I like the end of it. The end was yeah.
I get it, and that honestly, that's why questions 2 and 4. It's hard for me to pick, but because you learn something about someone every time that they say, "Oh, I could do whatever," or the pressure's on. You get to pick one thing. What means the most to you? You learn something about them, and I guess it's wedding pictures. That is a very popular answer.
Is it really?
Yeah, it really is. But you can't replicate. I mean, it's the once in a lifetime thing.
Yeah, our mind's going to fail us. If we live long enough and our internal medicine people can take care of us, keep our bodies going, our minds will fail us. And that's probably the biggest thing that I'm scared about. Is when that time comes, because it's going to happen unless a stroke or a heart attack or something kills us first.
Right.
Diabetes, our minds are going to fail us, and I want to hold on to everything I can.
That makes sense.
I'm afraid of spiders. So that's legit, by the way. I'm scared shitless of spiders.
Man, you're a grown man.
I'm a grown ass man, and I'll tell you right now, this is no fucking joke. I don't know if I've said this on the air, but I will bring Megan back on the air sometime to verify this. I was sitting on the toilet in the bathroom, and I saw a big ass spider crawl over by where the sink was and yelled for her to come in there and kill it because I was like, oh hell no. I am scared, terrified of spiders. Like it's a legit like, oh no, I can't.
I'm embarrassed for you.
You should be. It's fucking disgusting. But I'm telling you, I can't deal with spiders. They're little. They crawl in your sleep. They bite you. Your fucking hand falls off. That is bullshit. No, I'm not dealing with those things. So, anyways, before we turn this into Tom's 5 questions, Eric, get this last question out.
Last question, Clear. Question 5. You have $9.18 in your pocket. What all do you buy?
Don't overthink it, Eric. This is what I was telling you pre-production. Just go.
I'm going to tell you the first thing that popped into my head.
Okay.
A 12-pack of Busch Light.
There you go.
I almost said Skull and a 40 ounce. I almost said that. So, it is. I know where you live. I've been there.
As my taste have matured, as I've gotten older, Busch Light's not a bad beer.
And I don't know if you guys saw this. They're coming out with a new package label, Busch Latte.
I'm embarrassed for both of you.
Latte. It's amazing.
Yeah, oh gosh. Oh my goodness. All right. Well, on that note.
Okay. Yeah. All right. Let's wrap this up. On that note, if you enjoyed the show and liked what you heard and you want to hear more, you can find us on Facebook, Instagram, Twitter, and YouTube at Just Some Podcast. You can find us on the web, www.justsomepodcast.com. Email us. Tell us you like Busch beer too, just to embarrass Tom. Admin at justsomepodcast.com.
Eric, is there anything you want to shout out or you want people to know about or anything before we get off the air?
I've got nothing, y'all.
That's perfectly. That's a great answer. That is awesome. Me, I just had a blast. I already know we're going to have Eric back on the show. One, because we didn't even cover the second half of what we wanted to talk about. We just had so much fun talking about Cotard syndrome and stuff like that. Second, mental health is very important. Eric's obviously an awesome guy. We need to get him back on the show sometime. So I will save a lot of my stuff for the upcoming barrage that we're going to give him next time. Because the next time I'm not going to take it easy. I'm like, oh, you know the drill, Eric. Like, let's go. All right.
You guys got me broke in.
Exactly. Yeah.
But I had a great time, and I can't wait to have him back on the show sometime soon.
I agree. All right. Well, hey, you know what? On that note, I don't know what we're going to cover next week, but this is wrapping up our month of mental health awareness. Hashtag mental health awareness. Hashtag mental health is health. So hopefully, with the information that we have provided, we are helping to break that stigma of getting mental health. Tom, like I said, I don't know what we're going to cover next week, but I'm sure it'll be fun and exciting, right?
Capgras delusion. It's where everyone's replaced by somebody else. It's imposter syndrome type thing.
Correct.
I told you, I know the stuff that like I'm never going to see. That's the stuff I remember. So,
all right. Well, hey, on that note,
you should see Ben's face. He's like, "What the fuck just happened?" It's like if he just watched an 8-year-old paint the Mona Lisa. Like, did I just see that? Like,
this is synergism right here. This is mind melting. This is a whole bunch of cool stuff happening.
He said synergism, so that might be my new medical word.
Every once in a while, Tom's brain cells get together and they make a complete thought, and it just surprises the hell out of me. So,
well, fuck you very much.
Hey, hope everybody has a great week.
Hey, everybody, stay safe out there.
To get me right, I got one good reason to drink tonight. Head down.